Welcome. This is going to be a detailed live surgery video that shows how I like to do gastric bypass surgery. And I hope to use the video to not only show you the anatomy of the gastric bypass in the real living person, but to use the video and editing to show you the details about the anatomy and how we do the operation. We're going to start with some schematic diagrams, and then we're going to move into the live surgery video. I think this video is going to come in at a technical level that's just a bit too low for training surgeons. It might be good for medical students, but I really think it's for very interested lay people. I think of my patients who are engineers who like to know how things work. So think of this as a how things work for gastric bypass. First, a diagram of the gastric bypass. And in the gastric bypass surgery, we're going to use one of our special surgical staplers to separate the upper parts of the stomach into a very tiny upper part and a lower section. That upper part is so small, it's about the size of an egg yolk. Now don't panic, because it really is the size of an egg yolk, but in the long run, this tissue is stretchy, and after it heals, people are typically able to eat kind of small regular meals after surgery. Now, as I said, we're stapling across, we're separating the parts of the stomach, and so there needs to be a place for food to go. And so we're going to take a section of the small intestine, it's called jejunum, and we're going to attach it to that little stomach pouch. So this serves as the new food pathway, which is going straight down into the digestive section, and it's going to bypass the large lower part of the stomach and the section of intestine that's called duodenum. Now, the other thing that's happening in the surgery is that we're going to recognize that we still want our digestive juices to join with the food. So we're not only creating this connection, but also this connection downstream. So after the surgery is finished, food comes this way and digestive juices come this way. They mix and there's lots of normal absorption downstream. Now, as we'll discuss in the course of this video, the artist has use several simplifications for ease of understanding. And the first one of those simplifications I want to bring up is that there's lots of small intestine down here for normal absorption going downstream. A couple of other questions that come up just from the artist's diagram that people typically ask. This part of the stomach that's been bypassed, in the diagram it looks like it might twist or flip or rot or do something weird, but no. What the artist has left out, understandably, is that there are lots of blood vessels along this that we call the greater curve, and also where we call this the lesser curve. Those blood vessels hold that stomach in place and keep it healthy in the long run. Interesting side note, of course, we go into the gastric bypass not planning to undo it or reoperate at any point, but knowing that the stomach tissue is healthy leaves us nice options for the future. I mean, who knows, 2, 3, 6 decades down the road, we might want to put the parts back together. And although it's not plan A, that is possible as we go along in life. Now, the other thing that the artist has done, people ask sometimes, is the artist has shaded out this large section of intestine here. This is the colon. And just to clarify, we're not doing anything to the colon during the gastric bypass. We do move it around, but we're not operating on it. And the artist has just shaded it out so that it doesn't obscure what's happening with the small intestine. One other cool thing with this diagram, this section of jejunum, when we bring it up and attach it to something in the upper abdomen, it's called a roux limb. And this comes from the surgeon who devised it. His name was Cesar Roux, and he actually devised this option of bringing a section of intestine to use for many different operations, like for cancer surgery on the stomach or for complex biliary operations. And of course, it is good for our gastric bypass. So the full name of the gastric bypass is Roux-en-Y gastric bypass. The Roux comes from this doctor's name, and the Y is actually based on the letter Y. You can see this kind of looks like a Y right there. A few more points of orientation still using the diagrams before we get to the live surgery video. It would seem intuitive to work from the top to the bottom, and many surgeons do begin by forming the little stomach pouch first. It just turns out to be convenient for me to form the small intestine first, so I'm going to call that phase 1, formation of the roux limb. Phase 2 for me is going to be forming the small stomach pouch, or creating that stomach pouch, and then phase 3 will be attaching the parts together. There are going to be some other segments of the operation that I'll call housekeeping. They're very important, and we'll discuss those as we go through the live surgery video. Now, the gastric bypass procedure that's demonstrated in this live surgery video is a gastric bypass that I did recently using robot assistance. Robot assistance means that I'm still doing the surgery, but I'm sitting in the room at a surgical control panel, or what we call a console, and I'm using remote control to handle little tiny instruments that we place into the abdomen. And the robot allows us to use little tiny instruments that are very flexible and mobile, almost like small human hands, working through these tiny tubes through the abdominal wall that we call trocars. Many surgeons, and on occasion myself, we still do surgery laparoscopically without robot assistance. That's perfectly fine, but also suffice it to say that almost all bariatric surgeons these days use several small incisions, about the size of my index finger, and with the patient under full general anesthesia. Almost none of the video that you're going to see coming up is displayed at normal speeds. During the editing process, I had lots of fun speeding up and slowing down and freeze frame and using pointers. And my goal, I hope I've achieved, is to show you actually what's happening in the surgery and give you a decent understanding of the surgical process and techniques. The real live gastric bypass that serves as the source for most of the video used in this demonstration took about 65 minutes in real time. Okay, we're getting closer. Imagine that we're in the operating room, and imagine that our anesthesia colleague has our patient safely asleep. We're going to sterilize the abdomen. We're going to inflate the abdomen with CO2 gas because that gives us room to move around. We're going to put numbing medicine. I use Marcaine. There are lots of different choices. We're going to put numbing medicine into our incisions and then make our cuts. And once the cuts are made, we're going to put little tubes into the abdomen, through the skin, through the muscle, into that free inflated space. These little tubes are called trocars, and we use these tubes to have our instruments go in and out through the course of the operation, different instruments for different purposes, and the tubes have air seals that allow us to do that exchange process while keeping the abdomen inflated. Now we're going to transition into one more diagram that shows you where the trocars are, and it's going to orient you to the camera position. In this schematic of a patient's abdomen, here's the belly button, and here are the ribs. I typically use 5 trocars across the abdomen, through which we place our camera and our operating instruments, then one more at the breastbone for the liver retractor. This incision on the patient's right side is typically the most uncomfortable after surgery because the stapling instrument that we use here is larger than the others. You'll see this trocar again from the inside in a moment, and again at the end of the surgery. For most of the operation, the camera is going to be placed in this trocar near the belly button and will be pointed more or less towards the patient's head. However, the very first view you'll see is from this trocar on the patient's left side, looking towards the right. So now we're driving in through that trocar to look at the patient's right abdomen from the inside. We're going to stop for a moment and take a look at some of the anatomy in this neighborhood, looking across towards the patient's right. This normal structure that's shaped like a sail from a sailing ship is called the falciform ligament. Here we're seeing just a bit of normal small intestine. We'll see a lot more of this in a minute. This is part of a fatty sheet of tissue called omentum. It naturally covers the intestines, but it can be moved around. We'll also see more of this in tissue in the next few minutes. The fatty makeup of the omentum is normal, but in bariatric patients, the tissue thickens as part of the weight gain. Good news, it thins out with weight loss. This pink and white area is the inside of the abdominal wall. We can see one trocar already in place, and the next part of the video will be the placement of the last trocar before we begin surgery. Before we place the trocar, we're injecting some numbing medicine. As I mentioned, this is Marcaine. You can see the Marcaine collecting in the muscle here. And a bit more Marcaine. Here comes the trocar. This is the inside of the trocar where instruments like our stapler are going to go. The last preparation step is going to be to place the liver retractor, and that's coming up. Now the camera's looking from the belly button towards the patient's head. It looks to me as if this patient did a nice job on their liver shrinkage diet. This is a normal looking liver, and we already can see a decent part of the stomach peeking out from underneath the liver. We do need to lift the liver up in order to see the tippy top of the stomach where much of the operation is going to take place. This is the liver retractor coming into view, and we'll work this underneath the liver until we can see the very top of the stomach. I want to assure you that this video is accelerated and we're not trying to move this fast in real time, not inside the human body. Now we can see the whole stomach, including the upper end of the stomach at the hiatus. This is where the esophagus, which you won't see because it's traveling down through the chest, transitions to the stomach where we'll do our work. We've now finished the phase of surgery that I call setup, and we're ready to begin what I think of as phase 1, which is to prepare the rulem, which is the section of small intestine that will eventually attach to our new little stomach pouch. We're moving this fatty apron of tissue, that natural structure called the omentum that we saw briefly before, now getting a better view. We're not doing anything to the omentum, just moving it out of the way. As we roll the omentum towards the head, the transverse colon naturally comes into view. We're not doing anything to the colon, just moving and working around it. Now we're reaching our current goal, which is the upper end of the jejunum, the landmark called the ligament of Treitz. Starting with this landmark, we're going to walk the jejunum downstream for a measured length. My partners and I use a length of 100 centimeters. This segment of jejunum will become what we call the biliary limb. We've reached our target point where we want to use our stapler to cut across the jejunum. We use our energy device called the harmonic scalpel to make an opening for the stapler. We've opened up that space that we call a window, and in a moment we'll place the stapler to divide the jejunum. Before we actually do that, I want to use a video from another operation that we did to show you the stapler in detail and give you an idea about how it works. This is what we call a linear stapler. We clamp it onto the tissue where its function is to cut and to simultaneously seal the tissue, such as jejunum, that we prepared just a moment ago. The long slot that runs down the center of this disposable white cartridge is the pathway for the sharp blade that will cut the tissue. Each of the tiny rectangular spaces alongside that central slot contains a very small titanium staple that will deploy into the tissue slightly ahead of the cut so that the tissue is sealed to prevent leakage or bleeding. You can see that there are 3 interlocking rows of staples that deploy on each side of the cut. The stapler is a great tool, and you'll see us use it frequently during the case. Now, back to dividing the jejunum for our gastric bypass. We position the stapler carefully on the tissue and clamp it into place. Then we activate the stapler to cut and seal the jejunum. The robot shows us exactly what the stapler is doing at all times. That yellow progress bar indicates the movement of the blade with the staple deployment. You can see the blue indicator bar shows that the stapler is unclamping. Soon we'll see the cut and divided jejunum. This is what all those pretty staples look like. Since they're made from titanium, they're permanent, but also completely non-reactive for life. We're changing out instruments, and now we'll walk the jejunum downstream for a length of 150 centimeters to create the section that we call the rulem. We've completed our measurements, and these 2 sections of intestine that I'm aligning side by side are going to be connected together by what we call an anastomosis, so that digestive juices can mix with the food as it travels downstream. First, a schematic look at the anastomosis. We call this section the biliary limb because it carries the digestive juices, acid, bile, and pancreas juices from the lower stomach and the duodenum that will soon be bypassed once we divide the stomach in phase 2 of the operation. This is the lower end of the rulem, which brings food from the stomach pouch. The upper end isn't attached to the little stomach pouch yet, but it's laying out of frame down to the screen left. In order for the food and the digestive juices to mix, we'll need that connection that we call an anastomosis. Over the next few minutes, you'll see that anastomosis formed in this spot. After the digestive juices and the food flow together at the anastomosis, they'll travel downstream in the section that we call the common channel, mixing and absorbing as they travel through more jejunum, then ileum, for full normal absorption of all macronutrients. The first step in creating an anastomosis is to make a hole in each of the structures that we want to connect. We already saw that energy instrument that you're now seeing at the lower right of the screen called a harmonic scalpel. It uses energy to cut through the tissue while at the same time fusing the edges together so there's no bleeding. Surgeons have multiple tools they might use for this purpose. This is one that works well for me. Now that we've created matching holes, which are technically called enterotomies, our next job is to seal those holes together to provide a channel for the digestive juices to join with the food. The most common way of making this connection is to use our friendly linear stapler, but the robot makes it practical to accomplish suturing within the abdomen, so I prefer to use absorbable suture, leaving nothing behind but the patient's living tissue in the long run, where practical. After I've placed my first suture to line up the matching enterotomies, my job is to accomplish what we surgeons call a running suture. The suture will bring together the edges of my enterotomies, and I'm going to freeze the video so that you get a chance to see schematically how this will look. These are the edges of the enterotomies, and these little blue lines are approximately the locations of the sutures that will begin sealing the edges together. This would be the part that we surgeons call the back wall. I'm going to accelerate the video substantially so it doesn't get boring. Slowing down just a bit for the corner sutures because these are technically demanding. A little bit more to see here. I'll use that first suture now to bring together the edges of the far corner and the edges of the front wall. The robot provides tremendous magnification. In reality, these sutures are only 2 or 3 millimeters apart. Okay, so this is pretty much the completion of the anastomosis and almost the end of phase 1. First, a quick review of how this will work. Food enters here, digestive juice enters here, and the mixture travels downstream. Although this anastomosis is going to work fine, we've unavoidably created a potential problem that we'll need to come back to at the end of the operation. This space is an artificial gap that a random nearby section of intestine could potentially get stuck in the future if we don't prevent it. If some intestine did get stuck in here, it would be called an internal hernia. The gap we see here is one of 3 gaps that are going to exist briefly during the operation, but we're going to make sure they're closed up nice and snug before we finish the procedure. The silk suture that we're placing here will line things up and make it easier to come back to this space. It's just the beginning of the closure that we're committed to accomplish. So now we've got this roux limb ready to go, and it's resting down to the left. It needs to reach up to the stomach pouch at the top of the abdomen behind the omentum here. The main structures between us and the upper abdomen are the transverse colon here, and that big old apron of omentum here. Most surgeons bring the roux limb up and around in front of the structures, but I prefer an old-fashioned technique of tunneling the roux limb behind the colon. I feel like it's kind of a shortcut. To get this done, we'll begin by rolling the omentum and the colon towards the head. Naturally, we encounter the supporting structure of the colon called the mesentery. The mesentery contains blood vessels and lymph structures, but we know that if we go to the spot just in front of the ligament of Treitz, we'll find a space that has no internal structures where it's safe to create a tunnel or a shortcut for the roux limb to reach easily to the upper abdomen. We've successfully opened our tunnel or shortcut, and we're going to advance our roux limb towards the upper abdomen through this triangular tunnel. Moving the colon and the omentum out of the way. As the last step in the transition, we're going to open the fatty tissue between the stomach and the colon to confirm that our roux limb is ready to connect once we form our tiny stomach pouch in phase 2. This looks like it'll reach really nicely all the way to the top of the abdomen where the stomach pouch is going to be. Now we're in the upper abdomen, working underneath the liver, which was retracted at the top of the screen, and we're aiming to create our tiny stomach pouch here. In order to form the stomach pouch, we're going to cut the stomach in roughly this L-shaped configuration. We'll make the cut using our trusty linear stapler. We know that the fatty tissue along the lesser curve of the stomach contains a large blood vessel trunk and a branch of the vagus nerve. It's acceptable to cut across these structures using the linear stapler, but I prefer to peel them away from the wall of the stomach so that we preserve that blood supply and that nerve function. Once again, using the harmonic scalpel to cut tissue while also sealing the tissues to prevent bleeding. We continue to work through the layers of fatty tissue and tiny blood vessels. We draw the bundle of nerves and major blood vessels away from the stomach to protect them. Now we've successfully opened the gap that we wanted, making space to place our linear stapler. You might notice the stapler cartridge is blue. This simply means that the staples are a bit larger to handle tissue that we expect to be thicker along the lesser curve of the stomach. You'll see us transition back to white loads with the upcoming staple cartridges. This surgical absorbent pad in the right upper part of the screen soaks up oozing blood to keep our view clean. Of course, it's taken out before the operation is finished. This small fat pad is a key landmark in our surgical anatomy. We know that this is where the esophagus joins with the stomach. We want to place our stapler near the connection with the esophagus, but not to actually staple onto the esophagus. It looks like this is going to be the last staple load we need to finish dividing the stomach to form our small gastric pouch. We're going to be really careful with how we place this stapler because the spleen is hiding behind that omental fat, and the spleen is pretty delicate. As the stapler unclamps, we confirm that we've completed the planned division of the upper stomach. Now let's check out our tiny little stomach pouch, which we can see right here. That really is about the size of an egg yolk, but as I said in the introduction, people safely and comfortably eat small regular meals because this tissue is very stretchy after the healing process. We're investing a minute or two to clean off the fatty tissue so I clearly see the tissue layers of the new little stomach pouch. Okay, that's the end of phase 2. Now our job is to bring the key parts together like this. I feel I need to pause the case video for a minute to explain a little bit more in detail how this connection between the little stomach pouch and the intestine is going to be done. Earlier I gave you this diagram as an overview of the gastric bypass, and I like this diagram a lot, but it contains some simplifications that I haven't mentioned yet, and especially simplifications in the area of the gastric bypass connection that might be confusing if I don't give you a bit more orientation. As we zoom in on the connection between the stomach pouch and the intestine, it looks like the surgeon makes a hole on the front of the stomach pouch and fuses the end of the intestine to that hole. Now, I'm a terrible artist, but I think this diagram that I drew by hand will give you a more detailed idea about what we're doing surgically. Recall that when we want to create a new connection between sections of intestine, like the stomach and the roux limb in this case, we need to make a hole in each side and then seal the edges together. This brings up one of the differences. My preference is to make the hole I need in the stomach pouch not on the front wall, as in the professional diagram, but by removing a short section of the staple line that's near the bottom of the pouch. The reasons for this exact technique get into finicky surgical details, but suffice it to say I think my patients have less ulcers and less narrowing, we say stenosis, when I make the stomach opening in this way. The other key difference, and one that I share with almost all my surgical colleagues, is that we're making our jejunal opening near but not exactly at the end of the roux limb. We do this because it helps the intestine reach more easily to the stomach pouch, and also because the tissue is easier to work with since it wasn't stapled just a few minutes previously. As you can see from the diagram, this gives the top end of the roux limb a natural curved shape that we call the candy cane, or sometimes shepherd's crook. Now that you know what to look for, back to live surgery. The basic process for creating this connection, or anastomosis, will be the same as we used to create the small intestinal anastomosis in phase 1. The first thing we like to do is align our intestinal segments, in this case the stomach pouch and the roux limb, to sit stable side by side. Earlier, we used a grasper to create this alignment. For this anastomosis, it works better to place a back wall suture to stabilize the segments alongside each other. Now we've successfully brought our gastric pouch and our roux limb together, but so far there's no food channel. Our next step is to create holes in the stomach pouch and in the intestine at these locations. The trusty harmonic scalpel is the best tool I've found to cut the staple line so that we can create our planned opening into the stomach pouch. This is the special JP maneuver that I mentioned a moment ago. Now we're using a tool you haven't seen before in this video. This is a scissors with cautery. Like the harmonic, cautery can cut tissue while simultaneously sealing blood vessels, but it has slightly different characteristics than the harmonic scalpel that are useful in this location. We've just removed that little segment of stomach tissue with its staple line. As planned, we have a nice size hole in the stomach pouch right here. We'll use the cautery to create a nice matching hole in the root limb. And now we're using absorbable suture to fasten the edges together. Over the next couple of weeks, the suture will dissolve and the edges will fuse together as a natural part of the healing process. As you may imagine, this suturing is actually a fun technical challenge. I don't own stock in the company, but I can tell you that the robot gives us visualization and control that's way better than we could possibly get with manual surgery. We've just completed the back inner layer and the near or the left corner, and we'll suture together the far corner and then the front inner layer next. I didn't say it before, but this is an example of a sutured two-layer anastomosis. These few sutures coming up provide a pretty good view of how the sutures fasten the edges of the tissue together. This is not so different from sutures that were used to close skin cuts back in the day. We're finishing up the front inner layer of our two-layer anastomosis. According to routine, we plan to place an outer front row of sutures, but first we'll do a high-pressure leak test. I like to do the leak test before my last planned suture so I can use that suture to reinforce any weak spots. Fortunately, weak spots are really rare. The leak test begins with our anesthesia doc placing a tube across the anastomosis and then injecting air or blue dye under pressure. The tube should go from the little gastric pouch into the root limb like this. Let's see if I can track that tube in slow-mo as it actually comes down. Okay, and you can just see the contour of the tube inside the intestine. Great. Now we'll use our gentle grasper to pinch off the root limb. Our anesthesia doc will inject air under pressure through the tube, and you'll see the root limb expand a bit like a balloon. We dribble saline fluid across the area, looking for bubbles, just like you might check your inner tube for pinhole leaks underwater. Now it's expanding like it should. No bubbles, which is what we hope for. Next, we place our reinforcing outer front layer, and when that's done, we will have finished phase 3 of the operation. This video is significantly accelerated in this segment. Okay, phase 3 is done. The main remaining tasks will be to close all the surgical gaps that we left behind so we don't have internal hernias in the future. We're going down from the upper abdomen to the middle abdomen by rolling the omentum and the colon towards the head. This is the root limb, and you can see it still has some air in it from our recent air pressure leak test. In gastric bypass, when we reroute the intestines, we create at least 2 surgical gaps that intestine could potentially be caught in over time. When we tunnel the root limb behind the colon like I do, we have 3 of these surgical gaps. You can see 2 of those gaps right now. One is alongside the root through that shortcut tunnel we created behind the colon. The other is actually behind the root limb through the gap outlined here. This one has a name. It's called the Peterson defect. Over the next few minutes, we'll be closing all these gaps. This is silk suture, which does not absorb. It also causes just a bit of inflammation, which helps generate a bit of healthy scar to keep these spaces stuck closed in the long run. This particular stitch is being placed in what we call a purse string configuration. The gap that we call the Peterson defect is now closed. Next, we'll place a series of silk sutures to secure the roux limb to the edges of the mesenteric tunnel that we made earlier. These sutures will keep the roux limb or other intestine from sliding up into this gap like so. We've finished with these two gaps, and next we'll go back to that space we intentionally left behind in phase 1 of the operation. We call this the small bowel mesenteric defect. This is the third and last space that we need to close, shaped kind of like a triangle right now. Again, we'll use the silk suture, but this time we'll use a running technique to permanently collapse the space. We put things back where we found them. Now, of course, we take out all of the operating trocars at the end. The muscle tissue at most of the trocar sites is able to collapse back into place and heals great without needing any special work. However, of all the trocars that I place, this one at the patient's right side, the same one that we saw at the beginning of the video, is the largest. It needs to be this big to make room for our awesome linear stapler. But it's big enough that if we just remove the trocar, the gap might be loose enough for intestines to sneak in and get caught, which of course is a bad thing. That's why we always place the suture to close the muscle just after we remove the trocar at this one location, and that's why this one on the right side is the most sore. After we're finished tying the suture, we will put in still more Marcaine for the best numbing possible at this location. So that's a pretty detailed look at the way I typically do gastric bypass. If you're still with me, thanks for watching.